So now we're going to talk about pathologic jaundice. This is why we have a very frowny jaundice face here. All right, we do not like pathologic jaundice. We want to treat it as soon as possible because it can cause major effects. All right, so the criteria for pathologic jaundice. We got quite a few here, so get ready. Jaundice at birth within 24 hours. Remember, in benign jaundice, we talked about how it presents after 24 hours. But if you have it present really early, such as at birth or within 24 hours, you should be concerned. Something is causing an elevated bilirubin level very rapidly in the onset of life. Also, if it happens after the first week, so in the first week we have a physiologic jaundice happening anyway, but if it happens after the first week in terms of initiating, this is problematic. Something is coming after the physiologic jaundice and creating problems, so we need to work that up. Next is, the more chronic the jaundice, the more likely that the bilirubin will build up and deposit inside of the brainstem and the basal ganglia and lead to kernicterus. So we have to be worried and figure out why this jaundice is present for so long. Next, total serum bilirubin greater than 18. This is also problematic because we do not want the serum bilirubin being too high. Because remember, what happens when the serum bilirubin is too high? You have higher risk of kernicterus. So we want to keep these as low as possible, and you have to memorize the number 18. The number 18 is super important because at 18 is when you start doing phototherapy and other treatment options for term infants. So last one is that the infant has red flag signs and symptoms. So examples of red flag signs and symptoms are injuries to organ systems that could trigger jaundice. So any kind of respiratory, cardiac, neurologic, other kinds of symptoms, those are all very important, and vital sign instability, and also neurologic deficits such as lethargy, poor feeding, seizures. All of that would be major indicators that something's wrong with the jaundice baby. So red flag signs and symptoms. Remember, symptoms are also always very important, so always keep them in mind and consider them. So our first example of pathologic jaundice is a liver not uptaking unconjugated bilirubin. So our liver is always a super important organ in our body, which we tend to abuse every now and then. But as an infant, the liver is so critical in terms of removing the unconjugated bilirubin from the blood and converting it to conjugated bilirubin. But if there's a problem with liver uptake, you're going to have some severe issues. And here are some examples. Number one, neonatal hepatitis. When you have hepatitis, you have damage to your hepatocytes. So some of the hepatocytes are working, some of them are not working. So some are making conjugated bilirubin and some are not. So you're going to have a mixed hyperbilirubinemia because you have damage of hepatocytes that have already made conjugated bilirubin, and the conjugated bilirubin will leak out. Neonatal cirrhosis. Cirrhosis is a little different. Cirrhosis is complete destruction of the liver. If you have complete destruction of the liver, you're not making conjugated bilirubin anymore because there's no longer any UDP glucuronidyltransferase. So you get excess unconjugated bilirubin as a result. And our last one, sepsis and septic shock. This also causes a mixed hyperbilirubinemia, and we're going to talk about why. There's a lot of mechanisms involved here. So when you have sepsis and septic shock, you have decreased perfusion of the liver. If you have decreased perfusion of the liver, you've got impaired unconjugated bilirubin clearance. What does that mean? That means that unconjugated bilirubin travels through the blood attached to albumin to reach the liver. If you don't have enough blood flow to the liver, how is the blood going to reach the liver? How is the unconjugated bilirubin going to reach the liver? It's not. So you're going to have an excess of unconjugated bilirubin. But there's also more involved. You get lactic acidosis. I asked you that question earlier. Why does sepsis and septic shock lead to lactic acidosis? It's due to tissue hypoxia. So if tissues are going to be hypoxic and you have excess acid, the acid is going to displace the unconjugated bilirubin from the albumin. Okay? And you also have damage to hepatocytes and bile ducts. If you have damage to hepatocytes and bile ducts, you're going to release conjugated bilirubin because these hepatocytes and bile ducts have conjugated bilirubin in them because the hepatocytes are converting the unconjugated bilirubin and the bile ducts are transferring it to the GI tract. So you get a conjugated and unconjugated hyperbilirubinemia. This right here should say albumin. I will fix that on the presentation. So now, another form of pathologic jaundice. Increased unconjugated bilirubin production by the reticuloendothelial system. So the way I like to think of this one is that when you have a landfill full of trash, if you keep on adding more and more trash to the landfill, it's going to overwhelm the capacity of the landfill to get rid of the garbage, and it's just going to keep on building up. So that's going to be happening here. So an example of this is hyperviscosity. Hyperviscosity means you have too many red blood cells or too many cells within your system, so they'll all be broken down to make heme and to make unconjugated bilirubin. So if you have an excess hyperviscosity, they're going to be broken down. Excess unconjugated bilirubin, very high risk of kernicterus. You also have maternal fetal transfusion, so too much maternal blood entering the fetal circulation, and this can be caused by delayed umbilical cord clamping. And this is pretty self-explanatory why that happens. Next is maternal diabetes. You might be wondering, how would maternal diabetes cause hyperviscosity? So the reason why is that when you have diabetes, you damage the vessels and glycosylate the vessels in the placenta and decrease the amount of blood flow going to the baby. This is not gestational diabetes. This is more of a maternal chronic diabetes issue. And the hypoxia is going to lead to increased red blood cell production because the baby has erythropoietin available to increase red blood cells. So that diabetes can also cause hypoxia and hyperviscosity. Next is extravascular hemolysis, so extravascular, outside the vessels. An example of this is hematoma breakdown. Babies, if they had a suction or any kind of damage to their head while they were being born, can have a cephalohematoma, a hematoma of the head. So this means that the red blood cells in the hematoma are going to be broken down, and that heme is going to be converted to unconjugated bilirubin, and that unconjugated bilirubin can build up. In addition, we also have spherocytosis. Remember, in spherocytosis, the spleen is taking up all these spherocytes and breaking them down so it doesn't recognize them properly. So now you get more unconjugated bilirubin, overwhelm the UDP glucuronidinotransferase, and you have an excess of unconjugated bilirubin in the blood. So an important USMLE detail that's commonly tested is that you may have a patient who's very young who has a history of a extravascular hemolytic disease like spherocytosis, and they'll say they had an early cholecystectomy. So cholecystectomies aren't very common in young kids, and the reason why these kids get cholecystectomies is because the hematoma breakdown leading to excess bilirubin leads to pigment gallstones. Pigment gallstones are calcium bilirubinate, and that's going to cause cholecystitis and lead to early cholecystectomy. So key thing to know. Next is intravascular hemolysis, inside the vessels. So all these diseases have problems inside the vessels of red blood cell destruction or spontaneous breakdown. So first, G6PD. Without G6PD, glucose 6-phosphate dehydrogenase, you can't make NADPH, which prevents the RBC membrane from oxidative damage. So things that trigger it are favabines, sulfa drugs, nitrofurantoin, and antimalarials. And when these oxidative damages build up, they destroy the red blood cell, release heme, and guess what's made? Our old friend unconjugated bilirubin. Next, Rh incompatibility. So IgG antibodies from a sensitized mother to an Rh positive fetus will attack all the red blood cells, and the blood cells will all be converted into unconjugated bilirubin because of the hemolysis. And lastly, thalassemia. Thalassemia is where you have a defect in the hemoglobin production of the chains, and because the chains are faulty, these red blood cells can break down and be destroyed both by the spleen or by spontaneous destruction, and this heme that's released will now be converted to unconjugated bilirubin. Alright, next we're going to talk about decreased conjugation as a whole. So if you have decreased conjugation, everything's going to be unconjugated because you no longer can conjugate. So some examples of this. Crigler-Najjar syndrome types 1 and 2. We've talked about this before, that these syndromes are a result of a lack of UDP glucuronidinotransferase. Type 1 means you have none, and type 2 means you have a reduced amount. So what would happen? You would have an autosomal recessive disease with Crigler-Najjar type 1. You can't make UDP glucuronidinotransferase, so you get high levels of unconjugated bilirubin. Okay? Tons of unconjugated bilirubin, so high risk of kernicterus, because you cannot convert it at all. And you notice there's no response to phenobarbital. We talked about this in the first question that we encountered. It's a CYP450 inducer, and the CYP450s would allow the UDP glucuronidinotransferase to function. So if you can't have CYP450 induced to activate UDP glucuronidinotransferase by phenobarbital, it means that there's no UDP glucuronidinotransferase to work on in the first place. So the phenobarbital doesn't work because you don't have the UDP glucuronidinotransferase. So no matter how much you induce the CYP450s, you're never going to change the results, and you're going to keep having unconjugated bilirubin. So now type 2, we have a partial deficiency of the UDP glucuronidinotransferase. So this is autosomal dominant in contrast, and you have lower unconjugated bilirubin levels and a smaller risk of kernicterus. Why is that? Because it's only a partial deficiency. You don't have it all being gone, and that's why the phenobarbital can help. it'll activate the ones that are already present, and that will convert the unconjugated bilirubin to conjugated bilirubin. That'll be effective for these patients. Now, Gilbert's or Gilbert syndrome, whether or not you want to be French, determines your presentation and pronunciation. Stress-induced reduction of UDP glucuronidinotransferase activity. So when you have any kind of stress, such as starvation, such as sepsis, things like that, that will cause UDP glucuronidinotransferase activity to go down. So by itself, this will not cause a pathologic jaundice, but it can be associated with other disorders and cause a jaundice on top of that might be worse than it might normally present. If it's by itself, it will cause a mild transient jaundice. If it's severe, that'll be associated with another disorder and cause a jaundice in addition to the previous one. So hypothyroidism, in hypothyroid, everything slows down. And the UDP glucuronidinotransferase is an enzyme. Thyroid hormone upregulates it. So if you don't have enough thyroid hormone, you have less glucuronidinotransferase and you have more unconjugated bilirubin. And you also have decreased GI motility, so you have a more long time chance for the beta-glucuronidase to convert unconjugated bilirubin again and bring that back into circulation by enterohepatic circulation. So the decreased GI motility means you can have a longer exposure time for beta-glucuronidase to conjugated bilirubin, makes it into unconjugated bilirubin, and that gets reabsorbed, enterohepatic cycling. So now, I know we've done a ton so far. Here's the last one. Bile flow, decreased bile flow. We have a damage or problem with the biliary system, conjugated and mixed. So it's conjugated and mixed because you're damaging the bile flow after it's already been conjugated. And I call this a dam in the river bile. So cholestasis, sludging of the bile in the bile ducts. You have a backup of bile. So when you have cholestasis, it's all slowing down, it all backs up, and guess what you have? An excess of a conjugated bilirubin. You can't secrete it into the GI tract, so conjugated bilirubin builds up. Okay? Next, TPN, total parenteral nutrition. So because you're giving all the nutrition through the IV lines into the blood directly, you bypass the GI tract. There's no CCK, so there's no bile flow. So it's the same thing as cholestasis. The conjugated bilirubin will build up and cause problems. Now for the difficult things. So these are a little tricky, and we're going to go in full detail about these. We have Dubin-Johnson syndrome, and we also have Rotor syndrome. So let's start with Dubin-Johnson. I'm going to highlight the super important points, but I know there's a lot, but we'll go through each and every detail. It's autosomal recessive, so you're preventing hepatocyte secretion of conjugated bilirubin into the bile. So you have a problem with the anion transfer protein that doesn't let conjugated bilirubin go from the liver into the bile itself. So the conjugated bilirubin backs up and gets into circulation. You also want to know that Dubin-Johnson has black pigmentation of the liver. And this is actually not due to bilirubin, but due to epinephrine metabolites. And the way I remember this is Magic Johnson or Michael Johnson, the runner. They're all black. So it's a nice, easy way to remember black pigmentation of the liver occurs with Dubin-Johnson. And you also have elevated urinary coproporphyrin 1 to coproporphyrin 3 ratio. So that means you have more urinary coproporphyrin 1 than you normally do. Alright, and it's greater than 80%. The number isn't that important, but you should know that the ratio has increased very high. But the important thing is that the total amount of coproporphyrins in the urine is actually normal. So coproporphyrin is an intermediate in heme synthesis, which we'll talk about in a later slide when we talk about the porphyrias. And CP1, coproporphyrin 1, is excreted in the bile, and CP3 in the urine. So since the bile is all backed up, this CP1 will now go into the urine. So total coproporphyrins are normal, but ratio is elevated. So CP1 to CP3 is elevated. In normal people like us, usually the CP3 is elevated in the urine and CP1 is low. Another important thing is that when you give it radioactive IV dye, the liver lights up for a long time, but the gallbladder visualization is delayed or not visualized at all. So why does that happen? Remember we talked about there's an anion transfer protein that's problematic. That anion transfer protein cannot move the radioactive iodine into the bile system, so the gallbladder will never light up. So that's an important thing to remember is the liver will light up, but the gallbladder can't because of this faulty anion protein. Next, oral cholecystogram does not visualize the gallbladder at all. So when a person takes oral contrast and you try to take x-rays to visualize the gallbladder, it won't be taken up. And last thing you just have to remember, you get a clotting factor 7 deficiency as well. So you can have a higher chance of bleeding. Okay? Next is Rotor syndrome. This is the alternative to Dubin-Johnson. This one, on the other hand, is going to be a dysfunction of transfer proteins also, and that's going to prevent the conjugated bilirubin from entering the bile efficiently. So it's not the same, it's not a faulty anion transfer, it's not as efficient as going through. There's a dysfunction of the transport. Okay? Liver has normal histology, there's no epinephrine metabolites, and also you can actually see the liver and the gallbladder on oral cholecystogram. So these are some major differences here. Another huge difference is that the total coproporphyrins are increased in Rotor syndrome. And there's also a high CP1 CP3 ratio, but it's not as high as in Rotor syndrome or as in Dubin-Johnson syndrome. So Rotor syndrome has elevated total coproporphyrins and an elevated but not as high CP1 CP3 ratio as compared to Dubin-Johnson, which has a normal total coproporphyrin number but a very high CP1 to CP3 ratio. So I know we learned a ton in these last couple slides about pathologic jaundice. Now's your chance to write it all together. So write down everything you remember, especially Dubin-Johnson versus Rotor, and we will continue afterwards on the next set of the presentation.